beyond every greed and lure. I would like to welcome Miss Bhargavi, a final year student in SDM Medical College, Dharwad, presenting today as a case of gestational diabetes mellitus. I would also like to welcome our top-notch mentor, Dr. Sapna IS, professor in OBG SSIMS Medical College, Davangere. She is a well-trained gynec oncologist at Karidwa Institute of Bangalore and urogynecologist at Croydon University, South London. With her special interest in emergency obstetrics, basic and advanced endoscopy at Atlas Hospital, Bangalore, we welcome you, ma'am.
Thank you. Thank you.
I would also like to welcome Dr. Srinivas S. Sir, IMA President, Dr. Karunakar Sir, Karunakar BP Sir, or Honorable State Secretary, Dr. Shantala K. Ma'am, Chairman, Academic and Subcommittee IMA, Dr. Shabrata Ma'am, IMA MSN Chairman, State Chairman, Dr. Mithun M. Sir, IMA MSN Coordinator, Ms. Krupa Kumar, IMA MSN State Convener. Uh, I would also like to welcome all the students across the state. We bring you clinical case presentation series with comprehensive and detailed approach to obstetrics and gynecology with packed with tips and tricks to crack OBG Viva. Now I would like to hand over to Bhargavi to present the case.
Yeah, thank you. Um, Next slide.
Just a minute. I would also like to welcome Dr. Madhusudan Sir. Yeah, Bhargavi, carry on.
Yeah, yeah. Here's a 26-year-old patient named Pavitra Mallikarjun, who is a housewife by occupation, hailing from Dharwad. Her husband's name is Mallikarjun and works as a finance company worker. Their socioeconomic status is class 2 according to modified BG Prasad classification. Her obstetric score is, she's a primary gravida and was admitted on 2nd December. Next slide. Um, the patient came with history of 9 months of amenorrhea and was admitted for safe confinement. Next slide. History of present pregnancy, first trimester. It was a spontaneous conception. Pregnancy was detected by UPT and was confirmed by scan at 1.5 months. Dating scan and NT scan were done and were normal. Routine blood investigations were done. Folic acid supplements given. No history of excessive vomiting, increased frequency of maturation or burning maturation. No history of fever with rashes. No history of TB spotting or no history of pain abdomen. No history of exposure to any radiation. No history of any drug use. Next slide. Second trimester, quickening was fed at 20 weeks. Anomaly scan was done and is said to be normal. 2 doses of TT injection were taken at 16th and 20th weeks respectively. Iron and calcium supplements are taken. GST was done at 5th month and she was diagnosed to have impaired glucose tolerance. Her glucose level was 122 milligram per deciliter. She also gave history of burning maturation at the 5th month, which was diagnosed as UTI, and antibiotics were given for the same. Uh, she also gave history of increased frequency of maturation, increased thirst, but there was no history of headache, blurring of vision, epigastric pain, and vomiting. No history of pain abdomen, no history of PV bleeding. Next slide. Third trimester, she continued to perceive fetal movement. Growth scan was done and was normal. Iron and calcium supplements were continued. No history of any abdominal pain, PV bleed, or PV leak. Next slide. Obstetric history, married life is 1 year and was non-consanguineous marriage. Obstetric score, she's a primary gravida, no history of any contraceptive use. Menstrual history, age of menarche, 13 years. Her past menstrual cycle was regular, 4 to 5 days of flow, 30 days cycle. She changed 3 to 4 pads per day. There was no clots, no pain. She now has 9 months of amenorrhea. Her last menstrual period was 25th of March 2023, and her expected delivery date is December 1st, 2023. So period of gestation is 40 plus 1 weeks. Past history, not a known case of diabetes, chronic hypertension, tuberculosis, asthma, epilepsy, thyroid or cardiac disorders. No history of any surgeries in the past. No history of allergy to any drugs. No history of any blood transfusions. Family history, there's no history of diabetes in the family. Personal history, she is a vegetarian by diet with normal appetite. Sleep is disturbed. Bowel is normal and regular, but there is increased frequency of maturation. There's no history of any substance abuse. To summarize, here's a 26-year-old primary gravida of 40 plus 2 weeks of gestational age with impaired glucose tolerance was being managed by medical nutrition therapy. Next.
Yes. Before you go to general examination, Bhargavi, can you hear me?
Yes, ma'am.
Before we go for examination, this is important how you elicit the history, right? So
Yes.
first and foremost, in the identification, when you're telling about their address and all, education status is very important. Agree? So you
Okay.
have to tell the education status of both the husband and the wife, because whatever you are explaining, whatever the modalities of treatment, they should be in a position to understand that,
Yes, ma'am.
right? And always the positive history you are supposed to tell first. Okay?
Yes, ma'am.
So in the history wise. And the next is you are telling about in the first slide, in the first semester when you are telling, please go to that. I'll tell you history wise what you are supposed to do. History wise. You can put this
First,
examination later, because I just wanted you to continue and finish the history in a flow. But what you are
yes, ma'am.
supposed to tell is, you should see your previous slide. When you're coming with chief complaints and all, no, that I'm asking. Chief complaints, when you're taking the history, some more 2 slides you have to go behind.
Yeah.
Are you able to? No. Previous. Yes. Yeah, here. See, you're asking about history of present pregnancy, spontaneous conception, okay? And it was detected fine. Then you have to ask the leading questions about the history of all the negatives. Agree. Then
Yes, ma'am.
dating scan and NT scan, if she is educated, she'll tell you whether it's normal or not, isn't it? In second
Yes,
and
ma'am.
third trimester, you said according to the patient, according to the lady, it was normal. You're
Normal.
supposed to tell like that. Fine.
Yes.
Next second trimester, quickening you have told,
Yes,
and
ma'am.
anomaly scan was done. So
Yes,
what
ma'am.
is that GST? What you have written?
Ma'am, she had undergone glucose stress test at 5th month.
Yes. Is it normally repeatedly done?
Ma'am,
GST?
here in India, it is said to be done because it's a high risk case. This GST is done at 24 to 28 weeks.
Yes.
So
As
it
a
is.
screening test, isn't it? So we do oral glucose tolerance test. Very important to know whether there is. And in which conditions we do oral, sugar testing, GCT and GTT.
Ma'am, if in the first ANC visit itself, it can be done, ma'am, in high risk pregnancies. If they had a previous history of diabetes, pre-gestational diabetes, and if there is a
Yes.
previous history of diabetes in pregnancy, if the weight of the baby was more than 4 kg in the previous pregnancy.
Yes.
family
See,
history
now
of
you are
diabetes.
telling weight of the baby and all. So this you have to repeat it in the family history also. If there is a
Okay.
family history of they are obese, hefty people and birth weight is more than 4 kgs, or what else can be there? In the family history, you have not told. You have just mentioned family history about the diabetes, isn't it?
Yes, ma'am.
So many things. All the high risk factors you are supposed to tell in the family history. Okay. Next.
Okay.
Next slide. Yes, growth scan. And according to the patient, it is normal, right? Yes, no other specific complaints. See, in the previous second trimester, you said she had burning micturition and all that,
Yes, ma'am.
polyuria and all. Was it treated?
Yes, ma'am. She was given antibiotics for it,
That
and
you
she
should
told it
mention.
as.
See,
I've
that you should
mentioned it,
mention,
ma'am.
no? Huh?
I've mentioned.
Sorry?
I've mentioned it, ma'am.
See, in the show me in the second trimester. Why is it so? See, burning micturition and which was diagnosed as yes, she was treated for that. Why is it important to treat urinary tract infection?
Ma'am, it can cause hydronephrosis, renal complications in the baby as well.
Renal complication in baby. More than that, see, whenever we talk in pregnancy, when we are treating any comorbidities, it is related to mother and the baby, isn't it? What are its
Yes.
effects on the mother and what are its effects on the baby? In that way, we are
Okay.
supposed to tell. Okay. So it
Yes,
can
ma'am.
lead to preterm deliveries also, isn't it?
Yeah, yes, ma'am.
Isn't it? So that's why, and asymptomatic bacteriuria. So it has to be treated in the same way. It can lead to preterm delivery or IUGR also, isn't it?
Yes, ma'am.
Yes. Okay. Next third trimester, same thing, isn't it?
Yes, ma'am.
No other complaints. After the treatment, she was fine. What
Yes,
about her glucose intolerance? That one impaired glucose intolerance. What was done for that?
Ma'am, she was put on medical nutritional therapy,
Yeah.
and she came directly after that for third trimester only. She was told to follow up every 2 weeks, but
Okay.
she did not. But she did not follow up. She came directly for her third trimester this thing,
At
scans
term
for
she has
growth
come.
scans. Yes, ma'am.
Directly for
scans.
growth scan she had come. Okay.
Yes, ma'am.
Okay. Right. Next. So see, obstetric history is fine. So previously there was no history of see, menstrual history is fine. Next. See, in the past history, this comes in medical history you are supposed to write. Past history about blood transfusion and surgeries.
Yes, ma'am.
Isn't it? So
Yes,
this we write it as medical history. Medical history of diabetes, hypertension, tuberculosis. All this comes in medical history. Then you have to mention it as past history of any surgeries and
Yes.
blood transfusion. Agreed?
Yes,
So
ma'am.
once diabetic, once hypertension, usually it will be controlled, not cured. No. So it
Yes,
has
ma'am.
to be mentioned as in the medical list.
Yes.
Okay. Next.
Right.
See, this you have not written in detail, family history. So what all things, high risk factors? Now she is diagnosed with gestational diabetes. What all things you are supposed to ask? What all things you'll keep in mind and ask?
Ma'am, if anyone in her family had
One.
GDM in their pregnancy,
Okay. Then?
any history of diabetes in the family, and
Yes, then?
uh,
That is about comorbidities in the family, whether the mother, the father, okay, maternal aunt or all that you can ask. Then what else you'll ask about obstetrics?
ma'am, how was the baby delivered? Any history of hypertension during pregnancy?
Okay, obstetrics, related to obstetrics. So we were telling in the beginning, no? Any history of?
Large baby,
Yes, large baby,
weight,
then difficult deliveries, stillbirth,
difficult delivery.
or
Yes.
sudden IUDs, isn't it? All these
Yes.
polyhydramnias also will be there. Usually, that's why education status is important when we tell them about the complication.
Yes.
You are supposed to mention about it. Okay, the education status of both husband and wife. See, now all this you are supposed to write in detail in family history.
Yes.
Okay, next. So this is all fine. Okay, right. Now we'll go to examination. Okay. So she was managed only with medical nutritional therapy.
Yes.
Okay. She was diagnosed for the first time during pregnancy.
Yes, ma'am. In a 50.
Impaired glucose intolerance.
Yes.
Yes. Right. Continue.
General physical examination. Patient is conscious, cooperative, and well-oriented to time, place, and person. Moderately built and nourished. Ma'am, this BMI is pre-pregnancy weight, 55 kg, and height is 153 centimeters.
Pre-pregnancy.
So BMI is 23.5. Yes, ma'am.
Okay.
BMI is 23.5 kg per meter square.
Huh.
Vitals, temperature is afebrile on touch. Pulse rate is 82 beats per minute, measured in right radial artery, rhythmic, normal volume and character. No radio-radial delay, no radio-femoral delay, and all peripheral pulses were felt. Blood pressure 110 by 80 millimeters of mercury, measured in the right arm in sitting position. Respiratory rate 14 cycles per minute. Saturation was 99% on room.
Okay.
No pallor, no icterus, no cyanosis, no clubbing. no
See,
lymphadenopathy or
all
no
that
edema.
you should tell it in one sentence. Each one, no pallor, no ectus. It's not like that. How you have written? See, that is correct actually. Huh? Isn't it?
Okay.
No pallor, icterus, cyanosis, clubbing, or first pallor, then edema. Those two are important for us during antenatal period. The rest you should tell in medicine, cardiac patients and all. But here, pallor and pedal edema, you should see the order of common symptoms which are present. Accordingly, you should tell. Rare things, you should put it in the last.
Yes.
Okay, next.
Systemic examination per abdomen on inspection. Abdomen is
No,
uniformly
excuse me, before this systemic examination, you should examine the breast, thyroid, cardiovascular, respiratory system. Then you should come to abdominal examination.
Okay, ma'am.
You should not bypass any steps. Examination should go in order. You have done general physical examination. CNS, she is oriented to time, place, and person, you have told. Isn't it? Next, you should tell about breast, thyroid, very important, all the more in primigravida at term.
Yes, ma'am.
Why is it important for breast examination?
Ma'am, after in postpartum period for lactation and
Soon
any-
after delivery. Ideally, we are supposed to teach them, isn't it? During antenatal period, about the diet, about the exercise, and we should prepare them for delivery and in the lactation period, how to feed the baby, isn't it?
Yes, ma'am.
At least breast examination is a must. If there is a cracked nipple or retracted nipple, we can prepare her for lactation. And
Yes.
primigravida, all the more you are supposed to tell about all this. Okay?
Yes.
Yes, next.
Per abdomen.
Yes, tell abdominal examination.
Yes, ma'am. On inspection, abdomen is uniformly distended, flanks are full, umbilicus is central and everted. All corresponding quadrants move equally with respiration. Linea nigra and stria gravidum present. No scars, sinuses, dilated veins. Hernial orifices are intact.
So inspection, what is important for us in obstetric? So when we ask about obstetric examination, uterine
Yes, ma'am.
contour. What is
Yes,
uterine contour? It is almost like a pear shape at full term when there is longitudinal line cephalic presentation. Isn't it? It is almost like a pear shape which is broad at the fundus.
Yes, ma'am.
Isn't it? You have seen now
Yes.
full term pregnancy, how it will be. And that's how you are supposed to. On inspection, what all things you can see. You have seen normal deliveries.
Yes, ma'am.
So in second stage or when she has come for delivery, what all things on inspection you can per abdomen?
Ma'am, contractions like tense.
Yes, very good. Then
if the skin is stretched, shiny, and
yes, then
ma'am,
see
if
when
any
there is
previous delivery she has had scars of C-section.
Okay, fine. Then what else?
Excuse me, ma'am.
Yes.
Excuse me, ma'am. Ma'am, so sorry to disturb you. There is something covering your video, ma'am. Half of the video. Now it is clear, ma'am.
Okay.
Thank you so much, ma'am.
Okay. Yeah, tell me, Bhargavi.
Yes, ma'am.
On inspection, what else can be visualized? So you said about uterine contraction. What about the fetus?
Yes, ma'am. Location, like
what you can make out on inspection? Fetal movements, can you make out?
Yes,
Fetal
ma'am.
movements.
Yes, ma'am.
Yes, isn't it? You can make out
Yes, ma'am.
the kicking movement. Sometimes you can see. If it is polyhydramnios, it is over distended. So you are supposed to comment about this also.
Yes, ma'am.
Okay. So you should see about the uterine contour. You can see the scars, linea nigra, stria gravidarum, and then fetal movements. And if she is in labor, you can make out distended bladder. Isn't it?
Yes, ma'am. Yes,
You
ma'am.
might have seen, isn't it? Especially when they're in second stage, usually we will catheterize, so distended bladder. If she is in prolonged labor, if she is in prolonged second stage, you can see colonic distension also. Okay? lateral to the, in the both paracolic gutters, you can see colonic distension. So all this you can make out by inspection. So uterine contour you should tell, and you should tell about fetal movements if you can make out while examining the patient. Okay? Yes, proceed. Continue.
Palpation fundal height corresponds to 32 weeks with flank fullness. Abdominal girth is 95 centimeters at the umbilicus. Fundal grip, smooth, hard, irregular mass, suggestive of buttocks. Lateral grip, left side, the smooth curved resistance felt, suggestive of back. Right side, small knobs like irregular structures, suggestive of limbs. First pelvic grip, hard, globular, palatable structure, felt, suggestive of fetal head. Second pelvic grip, both hands are converging, suggestive of unengaged head.
So, what is it? Lie presentation position now?
Cephalic presentation, longitudinal lie.
Yes. So, first you should tell lie, isn't it?
Yes, ma'am.
So, 32 weeks flanks full means it is turn.
Yes.
Okay. So, it is longitudinal lie. Then, next presentation is?
Cephalic presentation.
Then?
Left occipital anterior.
Yes. Then? What is important next on palpation?
Presenting part can also be.
Yes, you have mentioned in second pelvic grip as unengaged head. How do you make out?
Ma'am, if both the hands are converging, then it is not engaged into the pelvis.
Yes. What else you are supposed to tell on palpation? See, on inspection, we told about uterine contour, isn't it? And fetal movements, distended bladder, all that. In the same way, on palpation?
No local rise of temperature and tenderness.
No, that is when there is a mass per abdomen and all in gynec. Here, amount of liquor, amniotic fluid, isn't it? In oligohydramnios, you feel full of fetus. Whereas in polyhydramnios, it is so much over distended, you will not be able to make out the fetal parts properly. Isn't it? Here, amount of liquor is adequate for the period of gestation. Isn't it? So usually by now, head should have been engaged in primigravity. Yes, it is unengaged head. So there are different causes for unengaged head or floating head. Okay? Yes, that you should anticipate. Now, she has impaired glucose tolerance, unengaged head, 40 weeks. You should keep all this in mind. Okay? Yes, next. Next.
CVS.
This you put it here. This you should put it first. And you are supposed to, in palpation, previous slide, you are supposed to tell about the symphysiofundal height and abdominal girth.
Abdominal girth 95 centimeters I've written. SFH I'll mention.
You have to measure always symphysiofundal height and abdominal girth. So we can have an approximate idea of the estimated fetal weight. You are supposed to calculate estimated fetal weight. Okay? Right. Next. Next slide.
Per vaginal examination. No?
This is over. This you should tell in the first. And breast and thyroid examination. Family history in detail. All this you have to put. Right. Next.
Per vaginal examination, cervix os is closed, minimally effaced, membranes are intact, vertex is at -2 station, and pelvis is adequate.
This is incomplete. Previous slide. This is incomplete. So there is something known as Bishop's score. Have you heard about it?
Yes, ma'am.
Yes, what all things we consider?
Ma'am, in Bishop's score, there is cervical dilatation, position of the cervix, station of the head.
So position of the cervix. Now we are, listen here. Position of the cervix you have not mentioned here. Cervix is posterior, central, or anterior. Posterior means still she is not in labor, isn't it? Many a times when we induce. If it is central means she may set into labor. Isn't it? Immediately or very soon she will set into labor. So position of the cervix is important. So os is closed, minimally effaced. Okay. If it is os is closed, can you make out membranes are intact?
No, ma'am, but she didn't complain of any PV leak as well.
So she may not know because she had urinary tract infection. Like that, she might be having in third trimester.
Yes,
She may
ma'am.
not be sure. So you can't write like that. Membranes are intact. Uneffaced, os is closed. Position of the cervix, it might be posterior. Vortex, of course, you can make out, isn't it?
Yes,
Whether
yes,
it is at
ma'am.
-2 station.
Understood.
Pelvis is adequate, agreed. So you should write what type of pelvis. Whether it is, normally it
Gynecoid.
will be
Normal.
gynecoid pelvis.
Gynecoid
Yes,
pelvis.
gynecoid pelvis, isn't it? That is
Yes, ma'am.
important. Next thing is CPD. You have not mentioned about CPD.
Yes,
See, you
ma'am.
told about the type of pelvis, clinical pelvimetry. But we have to
Yes.
assess CPD, cephalopelvic disproportion, isn't it?
Yes, ma'am.
And we have to reassess again in active labor.
Yes,
Because
ma'am.
here it is floating head, unengaged head, all the more. Yes. All the more you are supposed to assess this CPD. Okay.
Yes, ma'am.
Yes. Next. So your
Diagnosis,
diagnosis is
Primigravida with 40 plus 2 weeks of gestational age with impaired glucose tolerance with singleton pregnancy in cephalic presentation.
unengaged head. No, it is longitudinal line, cephalic presentation with LOA position. But you have not mentioned about auscultation. Isn't it? You are supposed to tell.
Yes.
Very important because she has not come for regular antenatal checkup and sudden IUD is common. Because she is primigravida, she may not realize the decreased fetal movements, the importance of fetal movements. So there could be sudden IUD in diabetic patients because of anoxia and all, isn't it? They are prone for sudden IUD. Usually we don't leave them till 40 weeks. Even though it is controlled, so once she's 38 weeks, we prefer to induce. What will happen if we leave her like this up to 40 weeks? Now she has not come for regular ANC and high risk pregnancy every 2 weeks they are supposed to come, isn't it? So she has not come. Now what all problems you anticipate in this lady?
Ma'am, fetal complications there can be stillbirth, intrauterine.
See, that is secondary. First we should deliver her, no?
Yes, ma'am.
Always
they can
in the
be post-
exams, see, you should consider yourself as a postgraduate in the labor room or a consultant. Now she has come with 40 weeks and she didn't have regular antenatal checkup. Especially it is important in the second and third trimester, which she has missed. So we are not supposed to miss now from our side when we are going to manage. And you have not told about the fetal heart rate. Very important here. Okay, you might have missed the slide, that's all. But that is also important because sudden IUD is more common in diabetic patients.
Yes.
Isn't it? Because of anoxia and vascular angiopathy and all that. So many causes are there, which will cause IUGR also. Right.
Yes,
then you have to see symphysiofundal height and the abdominal girth, calculate the estimated fetal weight. This is on examination part. Now, what problems? Now she is there in labor room. What problems you anticipate?
Ma'am, prolonged labor can be there.
Right.
And contracted pelvis, cephalopelvic disproportion can be there.
Yes, that is also we have missed it, isn't it? So it is important to do detailed examination. So now she has come. What is your management? Management includes investigations and treatment. So what will you do? She has come to outpatient department. She has come to your OPD. What will you do? How do you manage this case?
Ma'am, investigation, we have to do her blood glucose estimation.
You want to admit her or on OPD basis?
Yes, ma'am. Admit her, ma'am.
So first thing is admission. Admission, where do you want to do?
To the labor room, ma'am.
Yes, admission to labor room because she needs round the clock monitoring. Isn't it? So what in next is you have to do investigation. Before that, you have to do counseling. It is very, very important to talk to the patient, explain her condition, both to the patient, her husband and her family. Okay? You should tell about her condition that she has not come for regular ANC. Now she's 40 weeks and we have to admission and do termination of pregnancy either by induction of labor. Okay? Yes. Tell now what all investigation you do.
Ma'am, investigations complete blood count, hemoglobin level, blood grouping is done, serology is done, urine routine, thyroid profile, and blood glucose estimation is done.
Okay. Next, that's all.
Ma'am, biophysical profile can be done. And
Yes, very important. Before this,
Yes.
put an investigation. Still, so many things you have to do.
Amniotic fluid index
Biophysical profile, very important.
Yes.
And
AFI,
if required,
NST.
Doppler study also. See, listen,
Yes.
when we talk about ultrasound, biophysical profile with Doppler study. Why Doppler is important here?
Ma'am, any uteroplacental insufficiency?
Yes. Isn't it? Uteroplacental insufficiency chances are very high. So we may have to terminate pregnancy immediately. So biophysical profile with Doppler study is important in this patient. So how many times you want to repeat CBC? Ideally, CBC, blood grouping, serology, all this has to be done at first antenatal visit.
Yes.
Then what is more important here? Only GST I have written. If she has come for the first time. Yes, very important, isn't it? Especially when it is done in first trimester, we'll know her pre-diabetic status.
Yes, ma'am.
Isn't it? Yes. Then she's only on diet. So she had not come for regular ANC. So we have to calculate everything, isn't it? Is lipid profile important for her?
Yes, ma'am.
So you have not mentioned about it. Why is it important?
There can be increased cholesterol levels and fetal also macrosomia it leads to adipo. There will be increased adipose tissue formation.
What about HDL?
HDL also decreases, ma'am.
Then so is it cardioprotective?
No, ma'am. HDL is cardioprotective and it has been decreased here in cases of GDM. So long-term complications you can have of
cardiovascular complications in the mother, isn't it? So you are supposed to do lipid profile also. Then what else? What are the
retinal kidney examinations because of complications.
So you have to do fundoscopy. Renal function test you have not mentioned here.
Yes.
Yes, isn't it? So you know there's physiological changes in the kidneys and all the more in diabetes. What happens to glomerular filtration rate? And even in 50% of the cases, there may be urine sugar may be positive, even otherwise, isn't it? So you have to do renal function test, you have to do fundoscopy, lipid profile, all this. So how you should mention investigation means you are supposed to write this after writing diagnosis. You should write basic routine investigation in all patients what we do. Then specific investigation for GDL.
Yes.
See, lipid profile we don't do for everyone, isn't it? Here it is important. Fundoscopy we have to do. Then we have to do renal function test. And biophysical profile with Doppler study. We don't do for all patients. It could be for oligohydramnias or preeclampsia, isn't it? IUGR. And here in diabetes you have to do. Okay? Yes. Next. So what you want to do next? These are the investigations you do. Then.
Yes, ma'am. Ma'am, here she was on medical nutrition therapy, so I just put up what was advised.
Yes, fine, good.
If it is a normal weight woman, then your calorie intake should be 2000 to 2500 kilocalories. For overweight women, you put 1200 to 1800 kilocalories, which would include carbohydrates should form the 40% of it, fat should be around 40%, and proteins 20%. We should advise her high fiber diet. She should be advised 3 meals and at least 2 to 3 snacks in a day.
Instead of that, you can tell her to take frequently once in 2 to 3 hours, isn't it?
Yes, ma'am.
Because our people should understand, no, it is not how it is given in textbook. You should be able to counsel them. So she has to take frequently, right? Then.
Yes. And exercise, minimal exercise for 30 minutes.
What exercise you will tell her? To our patients.
Exercise, walking and...
Yes. Normal routine activities at home. Everything she can do. She can go for a walk also, isn't it? Yes. Then if a teacher, see, when you have to teach her about self-glucose monitoring, you should know her education status, isn't it? So for all patients, you have to ask about their education status. At least her husband also should be able to get involved and do glucose monitoring, isn't it? Yes, correct. Then next.
Next, if she's put on insulin therapy, these are the various insulin analogs available. Usually, we put them on intermediate acting NPH twice in the day, and after every meal, you can put a short acting insulin or a rapidly acting insulin.
What's the indication for insulin therapy, and what's the rationale? How much should be the sugar level?
Ma'am, it is indicated in pre-gestational diabetes, and even if there is uncontrolled diabetes, like if it is there, then you usually prefer on insulin is preferred, ma'am.
Yes.
Rationale, if it is around 140 to 160 mg per deciliter, it's 4 units. If it is 160
It
to
is better to
180,
keep at the upper limit of normal, isn't it?
yes,
It
yes,
should not, she should not go for hypoglycemia,
yes, ma'am.
isn't it? You have come directly to insulin. What about the drugs?
Ma'am, oral hypoglycemics, you can use metformin or else glimepiride. Metformin, 500 mg per day. Maximum dose can be up to 2,500 mg.
Yes.
With glimepiride, it's 2.5 to 5 mg OD. Maximum can be till 20 mg per day.
Which one you prefer?
Metformin.
Metformin. Does it cross the placenta?
Yes, ma'am, but there is no, it is said that there are no teratogenic side effects for it, so they prefer.
Yes. Yes. So we can give metformin during antenatal period when she comes for regular ANC, isn't it?
Yes.
In spite of that, if it is not controlled, every 2 weeks you have to repeat sugars. It is not controlled, then we'll go for insulin therapy. Okay,
Yes.
rapid or intermediate acting only. Okay, next one.
That's all.
See, this is in once you get a case of with medical disorder, you are supposed to talk about the medical control of the disease. Then you are supposed to talk about the obstetrics. Obstetric part. Now she has come. You have told about the nutrition diet. You have told about insulin, oral hypoglycemic drugs. This is for management of diabetes.
Management of diabetes.
Now, how will you manage obstetric part? Even whether it's eclampsia, hypertension. So always you have to divide like this: general management, diabetic management, then obstetric management.
Yes.
Right? Under those heading,
yes,
you have to write when you get a long essay. Yes.
Obstetric management, we try for a normal labor, ma'am, usually, but if the fetal weight is more than.
Now, Bishop score is less. It is anaphase Ross score. So, we have to take consent for induction. Different methods are there for induction. So, you get CPD to be assessed. If the estimated fetal weight, these are the points to be considered if we have to deliver her normally. And we have to consider all these points and then decide whether she can go for. And if the biophysical profile is normal, Doppler is normal, there is adequate amount of Leica and normal gynecoid pelvis, there is no CPD, then we should think of going for induction of labor.
Yes.
And we have to take consent, and there are different methods of induction of labor. So if she is for normal delivery, how will you monitor her? How will you induce? What is your plan of management?
Ma'am, induction, it can be done with oxytocin, injection oxytocin is given.
No. See, usually what we do, if she is diabetic, if she is on insulin, the previous day of.
Yes. The last dose is given on the previous day evening, and that day morning when we're inducing, we don't give
on the day of induction, we skip the dosage.
Yes, ma'am.
We don't give any. Yes, tell.
Dose, and blood glucose level is constantly monitored, ma'am.
Yes, then
to check if it is going hypoglycemic, then 5% dextrose can be given. And
we
once
usually start 5% dextrose. I told you it should be on the upper limit of normal. We don't. It is better. Our sugar levels are little more, but we don't want her to go for hypoglycemia because she has to deliver first, isn't it? Yes,
Yes, ma'am.
then what we'll do? So you start a IV cannula. This is how you're supposed to tell in the exam. The
Yes,
points in favor of delivery. And we told you all those points: Bishop score, estimated fetal weight, pelvis, Doppler, everything. Okay. Then
Yes,
there are different methods of induction. So you have to take consent for induction. Then on the day of induction, we skip a insulin dosage. Then we start our on IV fluids in labor room. Preferable is 5% dextrose.
5% dextrose.
Why dextrose? There is glucose. So we want it to be little more. We don't want her to go for hypoglycemia.
Hypoglycemia.
Then if required, we start her on insulin. In that
Yes.
insulin infusion, if required.
Yes.
And we check every 2 hourly, we check this glucose
Sugar.
levels. Isn't it? Then we induce. This is how we have to monitor her sugars, monitor the pulse, BP of the mother, and the fetal heart sound. Then you have to put a partogram. See, this is how you should go on telling each and everything, isn't it? Because you have to put a partogram, it is important. Isn't it? So you have to tell all this in the first phase and in the second stage. First stage, what you do, latent phase, and you should tell about latent phase also. Okay, then like that you have to start. Okay, latent phase, active phase, or first stage of labor. Next, second stage.
Second stage or delivery.
And in first stage, you should tell that we will start our own antibiotics, isn't it?
Yes.
We cover them under antibiotics. IV lines we start. Okay. Second stage.
Mom, second stage, there can be a difficulty in the delivery if the baby has
Yes,
shoulder
why?
dystocia.
Yes,
dystocia,
shoulder dystocia. So see, we are anticipating problem here. It may be 3 kgs or 3.5 kg, but the pad of fat over the shoulders is more, especially in diabetic mother, GDM mother. So we anticipate shoulder dystocia. So we have to give liberal episiotomy.
Yes, ma'am.
Isn't it? Liberal episiotomy is important. It increases the AP diameter of the outlet.
Yes, ma'am.
Yes. Then there are different techniques to conduct the shoulder delivery. So either of the one we have to do shoulder delivery. Then soon after delivery, what is important? Third stage.
PPH can happen.
Yes.
And delivery of the umbilical placenta.
Clamp. You should clamp it immediately.
And it can also precipitate fetal hypoglycemia because of fetal blood glucose in the fetus can reduce because of cord clamp.
Yes, vitamin K we should give. Then blood glucose of the baby has to be checked, isn't it?
Yes.
It is prone for hyperglycemia also. Then next, what will you do in fourth stage? You have to continue with oxytocin so that she should not have PPH. And then what else? She should feed the baby immediately.
Yes.
You should prevent neonatal complications.
Yes.
What are the immediate complications?
Respiratory distress syndrome can happen.
Yes. Then?
And
hypoglycemia.
Yes.
Isn't it? Hypocalcemia or respiratory distress syndrome. All these are important. That's why monitoring the baby is very important first few days. Okay. Yes. Next. Then what else you'll do?
Mom, after the pregnancy is done, postpartum 6 weeks afterwards, immediately after 3 days, we do a FPS and a PRBS.
Not 3 days. Next day only we do. Because soon after delivery, the sugars levels will come to normal usually, isn't it?
Yes.
So next day you repeat because we should know whether to continue with the same dosage what we used to give in the antenatal period, isn't it? Of oral hypoglycemic drugs or insulin. Many a times they will not require at all insulin, isn't it? So the next day you repeat, or soon after delivery, after 2 hours or after 4 hours, we have to repeat it because we would have given dextrose during normal labor, isn't it? It will be little upper limit, so better to do after 24 hours. Once they are shifted to postnatal ward, you have to repeat. Okay, next. Then?
Ma'am, then after 6 weeks, usually we repeat a GST again to check if she is diabetic, if there is a diabetes is started.
Why it is important is nearly 50% of them who are gestational diabetes are prone for later on for diabetes mellitus.
Yes.
Okay, that's the reason we have to do, and we should advise her contraception and also her exercise after six weeks onwards. She should start doing her physical exercise. Okay.
Yes, ma'am.
Yes. Next.
Mm.
What are the different? What are the effects of this diabetes on the fetus? What all things can happen? Why we give so much of importance to gestational diabetes or diabetes in general?
Ma'am, there can be fetal macrosomia, shoulder dystocia, fetal hypoxia, uterine fetal death. If it is a pre-gestational diabetes, chances of congenital anomalies are more.
Yes, congenital anomalies like what are the different
Yes, ma'am.
anomalies?
Cardiovascular is the most common one.
Which one?
The cardiovascular causes
Yes.
cardiovascular anomalies are the most common. In that, hypertrophic cardiomyopathy is usually seen, which is usually
Yes.
reversible.
Mm.
Then VSTs and transposition of great vessels can be seen.
Yes. Mm.
Then neurovascular abnormalities, anencephaly, holocencephaly, and all that. And
Yes.
GI problems, duodenal atresia is also seen.
Mm. What about
Then
intestine? Duodenal?
atresia is seen.
Yes.
Then
Isn't
they're
it?
more prone. Yes, ma'am.
So many, even skeletal deformities, so many problems will be there. That's why we have to get a targeted level 2 ultrasound to
Yes,
rule
ma'am.
out all the anomalies, isn't it? Especially in
Yes,
the
ma'am.
when we get an anomaly scan done, it is at a
Yes,
level
ma'am.
2. Level
Yes,
2
ma'am.
means we need a radiologist to go through the baby in detail, isn't it? So targeted ultrasound, we have to get it done.
Yes,
Okay. Yes. Then
ma'am.
what are its
Second,
effects on the mother?
effects on the mother, long-term complications are there, mom. She's more prone to diabetes mellitus, chronic hypertension, coronary artery
That is
disease.
later on, maybe after 5 years, 10 years, immediately. During pregnancy,
Immediate,
during labor.
mom, during labor, postpartum hemorrhage is more prone to,
Yes.
birth injuries are more common.
Yes. So what happens? Birth injuries. There can be perineal tears, cervical tear, because
Yes.
instrumental delivery, paraurethral tear. So when you're telling, no, you should tell during pregnancy. During pregnancy, in first trimester, second trimester,
in
that
first-
you should divide like that and tell. Then you will not miss anything.
In first trimester, they're more prone to abortions, recurrent abortions, mom.
Yes.
In second trimester, there can be maternal distress can happen, mom. Diabetic retinopathy can progress, and polyhydramnios can occur. And third trimester, there is usually PPH and birth injuries, and abruption can happen of placenta.
Yes. Yes. So during delivery also again there can be abruption, polyhydramnios, cord prolapse, because sudden the rupture of the membranes can lead to cord prolapse, isn't it?
Yes.
So and big baby while delivering, it may be a problem, isn't it? So perinatal injuries and perineal injuries. What can it cause problems for the baby during delivery? One is shoulder dystocia. Because of that, what can happen?
Fetal
Recently,
hypoxia
we had
can.
Yes.
Hypoxia.
Recently, we had a big baby, diabetic. She delivered normally around 3.8 kg. There was shoulder dystocia. We did all the maneuvers and we delivered. Yes.
Brachial plexus injury is more common.
Yes. Erb's palsy can be there. That's why that baby had little bit of Erb's palsy. So all this has to be counseled for the mother when they come for antenatal visit. Okay.
Yes.
Counseling is very, very important so that both the woman and her family are well prepared for the complication. Okay. Cardiomyopathy can happen for the mother, isn't it?
Yes, ma'am.
So you have to do counseling following delivery also, that she should take care of her health, isn't it? And control the sugar levels and spacing. Contraception is very, very important for them. Okay. If they're having repeated candidal vaginitis, repeated urinary tract infection, all has to be treated because it will cause preterm delivery. So it's the effect of gestational diabetes on the mother. Now, what's the effect of pregnancy on diabetes? See, both way you should think, isn't it? Effect
Yes,
of
ma'am.
diabetes on the mother, effect of
And
pregnancy on
pregnancy.
diabetes.
Diabetes.
Yes.
It can progress the vasculopathies, retinopathy, and renal function can decrease.
Just a
And
borderline can, the sugar levels can increase, isn't it? Because
yes,
pregnancy is diabetogenic. It becomes
Yes.
exaggerated. It becomes very more,
yes, ma'am.
isn't it? So,
Yes,
and
ma'am.
because of that, its effects, it may not be under control, and that will affect the baby also.
Yes.
Yes, right. Like that, you are supposed to tell in the exams. So, detailed history taking is important. Examination, I told you, uterine contour, everything, fetal heart
Yes.
sound, and amount of LICA. Then,
Yes.
when we ask you about management, you should tell both investigations, routine investigation and specific investigation particularly. Then, then when it comes to treatment during antenatal period, first, second, and third trimester, then once she is admitted for induction of labor, first stage, second stage, and third stage. If you divide and write, you will get more marks. And it becomes easy for you instead of writing like an essay.
Yes.
Isn't it? Third stage, then early puerperia, late puerperia. This is how you are supposed to write. Okay. See, by then you'll be completely covering everything.
Yes.
Okay. Right. Anything else? Others have any doubts?
Ma'am, what is sliding regimen of the glucose?
That is sliding scale means depending on the sugar levels. We give the
That
insulin
only.
dosage. Yes.
Yes.
So that sliding scale will be there. They'll see if it is between 100 to 200, only 10 units, 200 to 300, depending on that sugar levels. It is not fixed. See, before we will be giving 10 units. Suppose you consider before we are giving 10 units of insulin. Soon after delivery or after cesarean section, her levels will come down. If it is more than 200, 240, we may have to give her 12 units.
Yes, ma'am.
Every time you do sugar levels, according to that, we have to give insulin. That's why we call it as based on the sliding scale, we have to give. Unnecessarily, you should not give more insulin. It may cause hypoglycemia. And I told you it is more dangerous. She may have ketoacidosis also. Later, we won't know. So better she is at the upper limit. So that is sliding scale. Usually in the post-operative period, first 24 to 48 hours following delivery, either by cesarean or normal delivery, we follow this sliding scale.
Yes.
Okay? Yes.
Okay.
Right.
Anybody who has doubts can unmute yourself and ask, or you can just drop them in the chat box.
Krupa?
Yes, sir.
Mithun? Mithun?
Hello, sir. Hello, sir. Yes, sir.
Yeah, we are online.
Yes, sir. Yes, sir. I am online, sir.
OBJ Aitan in the posting, sir.
Yes, sir.
No doubts.
Either they know everything or they don't know anything.
They know little.
Okay.
Yeah, Mithun.
Yes, sir. Yes, sir.
Mithun. Yeah,
Yes,
take care. ಯಾರಾದ್ರೂ ಕೇಳು questions
sir.
ಕೇಳ್ತಾರೆ, then we can call it a day.
Yes, sir. Sure, sir. Yes, sir. Thank you, sir. Yeah. If anyone of you is having any queries or any questions to be asked, please do ask.
Bhargavi herself can ask.
Yes.
They have to study first to ask questions.
Yeah. Bhargavi, you are there online?
That's the problem.
Yes, sir. Yes, sir.
Yeah, you can. Yeah. Then shall we close the session?
Yes.
Mithun?
Sir, yes, sir.
Yeah,
sir.
on behalf of IMA Karnataka State Branch, I thank my classmate, Dr. Sapna from
Thank you
Davanagere,
so much.
and I am really proud and glad that my classmate has become a professor and unit chief. And it was nice that she is guiding the students so well. And ಒಂಥರ ಹೊಟ್ಟೆ ಕಿಚ್ಚಾಗುತ್ತೆ ನಮ್ಗೆ ಯಾಕಿಂತ ಟೀಚರ್ಸ್ ಇಲ್ಲ ಅಂತ ಹೇಳಿ ಆ ಟೈಮಲ್ಲಿ. We struggled a lot to complete our OBG postings at that time. Thank you, Sapna, on behalf of Karnataka State Branch.
Yeah,
And
thank
I
you.
request you to continue this program, and we request you to kindly be supportive to IMA MSN. MSN is called Medical Students Network.
Sure, sure.
Being in IMA, I was involved with many of the subcommittees, and this is one of the very good students forum where we want to guide the students to become the leaders of IMA in future.
Yeah, that's good actually.
Yeah.
Even I feel
So thank you
honored
very
and
much.
thank you so much, Madhusudan.
Yeah,
For
thank you.
involving
Thank
us.
you. I thank Bhargavi also. She presented well, and keep presenting these things, because these such forums will definitely give courage and confidence to face the real exams. Thank you, Bhargavi, and thank you
Thanks.
all the participants who participated in this clinical session. Kindly join for the next session on next Thursday by 7 o'clock.
Thank
We'll
you,
come up
IMA
with,
and IMA team also for making it very nicely, arranging everything. Maybe a little bit of hurdle from my side. There was little bit of issue. Otherwise, it was nice discussion, and special thanks to Dr. Madhusudan for including me. Thank you so much.
Yeah,
Excuse me,
at
ma'am, and
Digital
also the
India,
recorded
we need
session.
to. Yeah, this session is available on YouTube link, the same link that we have circulated, and you can, Mithun, make it a point to circulate that clip and that
Yes, sir,
link
sure, sir.
among other students, so that they can listen to this session on their leisure time. Okay.
Yes, sir. Yes, sir. Yes,
Thank
sir.
you.
Definitely, sir. Yes, sir.
Thank
Thank you,
you.
sir. Thank you, ma'am.
Thank you, Sapna. Thank you, everyone.
Yeah,
Bye.
okay, thank you. Thanks everyone. All the best for exams.